Hello and welcome. Today we're diving deep into a serious heart condition called infective endocarditis. This infection can have severe consequences if left untreated, so understanding its causes, symptoms, and management is crucial. Infective endocarditis at its core is an infection of the inner lining of the heart, the endocardium. But what causes this infection? Bacteria are the most common culprits. These bacteria, such as Staphylococcus aureus or Streptococcus species, typically enter the bloodstream through various means. This could be from intravenous drug use, dental procedures, infections elsewhere in the body, or even indwelling catheters. Less commonly, fungi or other microorganisms can also cause endocarditis, particularly in individuals with weakened immune systems or long-term IV catheters. Underlying heart conditions like valve defects or prosthetic heart valves provide a fertile ground for these microorganisms to latch onto and multiply. Let's unravel the pathophysiology, or how this infection unfolds. Once bacteria enter the bloodstream, they tend to adhere to damaged or abnormal heart valves or the endocardium. These microorganisms then begin to multiply and form colonies known as vegetations. These vegetations are not just clumps of bacteria, they're complex structures composed of bacteria, platelets, fibrin, and inflammatory cells. As they grow, these vegetations can damage the heart valves, leading to valve dysfunction. Furthermore, fragments of these vegetations can break off and travel through the bloodstream as emboli. These emboli can lodge in various organs, such as the brain, kidneys, or lungs, leading to serious complications like stroke, kidney failure, or pulmonary embolism. The body's immune response to the infection also contributes to the damage, leading to inflammation and further tissue injury. Now let's talk about who's at risk. Infective endocarditis is relatively rare, but certain populations are more susceptible. Individuals with pre-existing heart conditions, such as congenital heart defects, damaged heart valves due to rheumatic fever, or prosthetic heart valves, are at significantly higher risk. Intravenous drug users are also at increased risk due to the direct introduction of bacteria into the bloodstream. Patients with indwelling catheters or implanted cardiac devices are also at risk. And finally, those with weakened immune systems, such as individuals with HIV/AIDS or undergoing chemotherapy, have a harder time fighting off infections and are more vulnerable. The symptoms of infective endocarditis can be quite varied and may develop gradually or appear suddenly. Common symptoms include fever, chills, fatigue, and night sweats. Heart murmurs, often new or changed, are also frequently present. Other signs may include shortness of breath, cough, joint pain, muscle aches, and skin changes like small red spots called petechiae or painful nodes on the fingers and toes called Osler's nodes. Splinter hemorrhages, which are thin, red-brown lines under the fingernails, can also be observed. It's important to remember that not everyone will experience all of these symptoms, and the specific presentation can depend on the location and severity of the infection. Diagnosing infective endocarditis requires a thorough approach. The modified Duke criteria are the gold standard for diagnosis. This involves a combination of clinical, microbiological, and echocardiographic findings. Blood cultures are essential to identify the causative microorganism. Multiple blood cultures are typically drawn over a period of time to increase the likelihood of detecting the bacteria. Echocardiography, both transthoracic and transesophageal, is used to visualize the heart valves and look for vegetations or other signs of endocarditis. Other diagnostic tests may include chest rays, electrocardiograms, ECGs, and blood tests to assess organ function and inflammation. Infective endocarditis isn't simply one single condition. It can manifest in different forms depending on the severity and course. Acute infective endocarditis develops rapidly and is usually caused by highly virulent organisms like Staphylococcus aureus. It's often associated with severe symptoms and requires immediate medical attention. Subacute infective endocarditis, on the other hand, develops more gradually, often caused by less aggressive organisms like Streptococcus viridans. It can be harder to recognize initially but can still lead to serious complications if left untreated. Prosthetic valve endocarditis refers to infection involving a prosthetic heart valve, which can be particularly challenging to treat. And finally, there's device-related endocarditis, which is associated with implanted cardiac devices like pacemakers or defibrillators. Treatment for infective endocarditis typically involves a prolonged course of intravenous antibiotics, usually lasting 4 to 6 weeks or longer. The specific antibiotics used depend on the identified microorganism and its antibiotic sensitivities. In some cases, surgery may be necessary to repair or replace damaged heart valves or to remove large vegetations that are causing complications. Surgery is also often required for prosthetic valve endocarditis or device-related endocarditis. Supportive care, such as managing heart failure or treating embolic complications, is also an important part of the treatment plan. Preventing infective endocarditis focuses on reducing the risk of bacteremia, or bacteria, entering the bloodstream. Good dental hygiene, including regular brushing and flossing, is crucial. Prophylactic antibiotics, meaning antibiotics given before a procedure, are recommended for certain high-risk individuals undergoing dental or other procedures that could introduce bacteria into the bloodstream. This includes patients with prosthetic heart valves, a history of infective endocarditis, or certain congenital heart defects. Avoiding intravenous drug use and practicing proper infection control measures, such as hand hygiene and sterile techniques for indwelling catheters, are also essential preventive measures. The prognosis for infective endocarditis can vary widely depending on several factors, including the causative microorganism, the severity of valve damage, the presence of complications, and the patient's overall health. Early diagnosis and prompt treatment with appropriate antibiotics significantly improve the chances of a favorable outcome. However, even with treatment, infective endocarditis can lead to serious complications, such as heart failure, stroke, kidney failure, and death. Recent research has focused on improving diagnostic methods, developing new antibiotics, and refining surgical techniques to improve outcomes for patients with this challenging infection. Ongoing research into biofilm formation, which plays a crucial role in the pathogenesis of endocarditis, may lead to novel therapeutic strategies in the future.